We're going to get started, folks. Tēnā koutou katoa, my name is Pete Hodson, and the fire exits are there, and there's another one there. And if you're needing to use them, would you please gather at the bus station on Albany Street? And if you're concerned about the gas leak and the fire engines and the traffic, which is why we've started late, I'm advised that you shouldn't be. I'm not sure whether that's reassuring at all. But anyway, it's time we got started. Thank you for coming, and a big thank you to the museum for hosting this and doing all the arrangements. It's most welcome. We've dropped the ball on communication with the New Dunedin Hospital in recent months, and so this meeting is part of a process to redress that. For a long time we said nowhere near enough, even to the point where Te Whatu Ora apologised some weeks ago publicly, and that was pretty helpful. And there was a press conference earlier today. I was in, can you hear that? Is that you picking me up? Okay. I was in Wanaka giving a talk yesterday, etc. So we're now seeking to engage, and in doing so, I'm wanting to take you through a bit of a presentation, I hope for about 15 or 20 minutes, and then open the floor up so we can get questions. And when we get to questions, those are the other four people listed alphabetically by their first name who will be helping me. And you can see there that what their roles are in this new hospital project. And I would simply say that these four people, and there are a few others around, have made an extraordinary difference to the quality of what we're getting as a city and as a region for many, many years. They've done it for many years. I'm going to ask for two lots of respect in this in this gathering we have. The first is to respect those people. They are people who don't take decisions. They give advice, and they give it freely and frankly, and they give it without hesitation. And they'll do that again tonight. You'll sense that. And the second is, can you please be respectful of each other? There's lots and lots of agendas in this room. I can see pathology there, the role of the university there. I think I can just about see someone who's interested in artwork. There are people who are concerned, of course, about the cuts or the savings or whatever it is you want to call them. And in the course of my talk, I want to get into a bit of detail with that. So let's get on with it. We've got, I hope, plenty of time to answer questions. Just to give you a feel for it, in case there's anybody in the room who thinks that the new hospital is the same size as the existing one, it's about a quarter bigger. So the existing hospital is near enough to 70,000 square metres. So that's the ward block and the clinical services block, the children's pavilion, and all the other bits that we are replacing, all added up together, come to near enough exactly 70,000 square metres. The new hospital is near enough exactly 90,000 square metres. There's arguments around the edges, but that's roughly the case. The more important thing is that it's built more efficiently. It's built to a grid so that it can be flexed in the course of the next 50 or 60 years. And if you go to the existing ward block, for example, you'll remember vertical columns in the middle of everything. And hopefully this hospital will have a greater efficiency of movement. It'll be augmented, of course, by IT. And then the second paragraph there, I'm going to ask Raymond, if he would mind standing up. There he is. He's finished standing up now. Raymond is from Workforce Central Dunedin, and that's a skills hub designed to try and address one of the most significant issues we've got, which is finding enough people to build this thing. And that risk, if you will, is also an opportunity for your granddaughter to become an electrician if that's where your granddaughter is headed. Those are just some basic figures. It will be a 5-star green hospital, the first of its kind in New Zealand. It's very big. And the reason it's very big is that it's a full replacement. It's not just an extra wing or an elective surgery bit that's been added on, or a children's ward or whatever. It's near enough, the whole lot, except for cancer and mental health, cancer and blood services and mental health. You can see the other bits of that. I won't read them out. If you can read them, well and good. I think most of you will be able to. I'm going to keep clicking on. And I'm not going to dwell on this either, except to let you know that it exists. Design principles are where architects spend a lot of their head. They think about it a lot. And so you can see that there's a bunch of fine-sounding sentences and words there, which are what is designed, which is there to try and give architects the inspiration that they need. And on the left-hand side, there's a sentence there which says that clinicians have been engaged in this project, community has been engaged in this project, and mana whenua have been engaged in this project, to my knowledge anyway, for more than 5 years and counting. So there's really significant engagement, including last week, including next week. It just goes on. When we the smaller of the two buildings is the outpatients building. It runs to about 13 and a bit thousand square metres, and it looks like that from Cumberland Street, and there's a few bits and pieces in there about it. It's due to be concluded at the end of 2025. It's important to realise why we are building this thing in 2 stages. We were not originally, we were going to build it as a job lot, and we split it into 2 for clinical reasons. The clinical reasons were that the ward block that we've got now and clinical services block that we've got now may not last the distance through to 2029. Just may not handle it, all of those winters. This was even before COVID. And so, as it happens, I went to see the Minister of Finance and asked him whether he had the readies to put in the outpatient building earlier, and he said yes. And so that's why that building is opening earlier. And then the second thing to say about it is that it's on the other side of the street because it's culturally different. It's about wellness as opposed to illness. And so there's some thinking around that I'm not equipped to go into in any great depth. But the idea of having 2 buildings and having an outpatients building that wee bit more like an airport than a hospital, if you see what I mean. It's aiming to get people who are reasonably well through quickly and efficiently. So that's the thesis behind that. It also means that the linkage, the all-important linkage in Dunedin with the University of Otago and the Polytechnic is made easier by that arrangement. And finally, it means that we can develop a construction workforce to build that building, which we can then go on to partially address one of the biggest risks we've got, which is finding enough people to build the next building, the big one. That's what it looks like, or at least an artist's impression of the ground floor of the outpatients building. It won't look like that, it'll always be different. It's just an artist's impression, but it'll be roughly like that. So things to point out are, I think if you can see the effect of mana whenua design sitting right there, you can see that someone's decided to put up some pretty fancy artwork right there, and you can see the use of the stairs. The stairs become the obvious place to get up to the first floor, just because using the stairs is healthier than using a lift. And that's what the building looks like from Castle Street side, from the fire station. And you're looking straight down St Andrew Street towards the northwest, I would say. Castle Street is running from right to left in front of you, in front of the building just there. Here's a slide which makes two other important comments. One is that a health system is not a hospital, it's a hospital plus a whole lot of other things. And those other things are all of that primary and community health planning and thinking that goes on. And that's a really big part of what Te Whatu Ora has to think about as it builds the hospital. And indeed, that thinking is, of course, well underway. And the second paragraph uses the words transformation and transition. We are tending to use the word transformation for changes that need to take place at the secondary and tertiary level, the use of generalism, the greater use of telemedicine, the greater use of day surgery, just to give you some examples. The word transition we tend to use as being the bit about how the hell do we shift from one building to the next. What do we do on this particular Friday? Which services are going, when and where? What are we going to do about, how are we going to make sure that we've got a good transition so that hopefully the public see very little difference or very little interruption in the service. This is from Quinn Henderson, who's South Base, the main contractor for the big building. They are a New Zealand company. The main contractor for the outpatients building. They're currently building the new Tarangahira on Albany Street now for the University of Otago, and there's some comments there which you can read for yourself. The main contractor for the big building is called CPB, which is not a New Zealand company, but one with shareholding mainly in Spain and Germany. Then, as far as the building is concerned, you've all watched these big metal things come and go, and you've watched Hameroid do the bang the place to bits. And the piles are now tied horizontally, and so this is a building that is due soon to come out of the ground, is the terminology they use. And so that'll happen around about June or July. There'll just be a whole lot of steel beams go up, and for those of you who've been saying, well, it's a long time since they knocked over the chocolate factory, where the hell's the hospital? The answer is you'll begin seeing it in about June. So this is just a statement to remind us that we get to build the outpatients in order to relieve the existing building. And we then have a bit more room to move in that building, I hope, to get us through the next 4 or 5 winters until the inpatients building opens. That's easily the larger of the two buildings, and it's going to be the dominant it's going to be dominant. It's a really big building, and we've had to be so thoughtful about everything. Shading of the railway station was a big concern some years ago, for example. Now we're getting into the cost escalation bits, the cuts or the savings or whatever it is that you want to call them. And you can read some stuff there, but I'm going to dwell a little bit on the first dot point and say to you that most of the $90 million savings, way more than half of the $90 million savings, are non-clinical. They might be important, like we're losing one of the bridges and we're losing the pavilion, and I'm sad about both of those, but they're non-clinical. They don't affect patients. They don't affect the clinical workings of the thing. And they include filling in a little bit of the great big light well that goes down for 10 or 11 stories. It only goes down for 8 or 9 now, and uses some of the bottom of that light well, which wasn't ever particularly well lit, for fill-in space. It takes a lot of the ins and outs of the facade and straightens them, and that saves money. The pavilion, which I personally didn't like when I first saw it and have subsequently fallen in love with it, and now I have to say goodbye to it, is triangular shaped, and that's pretty inefficient. And we've managed to shift some machinery around and make some savings with some bits of engineering and so on. Non-clinical. And then there are some clinical ones, and I'm going to go into depth in those because I'm imagining that's where the public interest is. Most of the changes that are clinical are deferred expenditure. That is to say, on opening, they'll be shelled, or they'll be built but not fitted out. That is a way of simply deferring, as I say, deferring expenditure, and allows us to expand the hospital when the need arises. Of course, when the need arises, we'll still have to find the money to fill in the shell spaces and deal with things that we put in the shell spaces, like storage or whatever. These are not straightforward things, but they are common. It's common to shell part of a hospital when you hope it's going to last for 50 or 60 years. And then on top of that, there's one cut which is not shelling or deferring, but is permanent. And that's reducing the number of theatres by 2. Theatre numbers are a bit difficult to understand, and we've got a handout to make that easier for you, which I'm going to tell you about in a minute. But that is a permanent reduction. We won't be able to retrofit that. We're reducing it by 2 theatres, and I'm going to go into some more detail on the next slide as soon as I've told you that there is no change to the outpatient building. Here's some numbers. The bed numbers show that the current hospital, there's different ways of counting beds. We've used the same methodology, we promise. 367 beds becomes 410. And in the thing called the detailed business case, which Cabinet signed off, 10 of those 410 were shelled, and now we're going to shell another 12 and take it up to 22 shelled beds. The theatres have been reduced by 2. Do you remember? So that's where, 28 is now 26. And they're proper general theatres that are being cut. Theatres it's a term that's difficult. 4 of those theatres are endoscopy rooms, and then there are other rooms which are complicated, and people like Sheila can explain them when she gets to talk to you. And then there is 1 MRI and the only PET scan is being shelled. So instead of opening with 3 MRIs, it'll open with 2. Instead of opening with 1 PET scan, it will open with none. But both of them will be shelled so that they can be plugged in later. And actually plugging in the MRI and PET scan is relatively simple. So that's the detail of the clinical changes that's caused the fuss. And then of the other 2 things called ED beds and a 23-hour ward, I've put in to make another point altogether. So bear with me. The beds on the left, 367 and 410, do not include ED beds. They don't include ED beds because when you go into ED, you're not admitted. You're not an inpatient. You're in emergency department. And so those beds are not, those 31 becoming 53 is not shown in the left-hand figure. Nor is the 23-hour ward. It's a bit of a strange name, and I've had to remind myself, be reminded of its function. But listen to this. As we move more to day surgery, as we move more towards a 10-hour day, not an 8-hour day in theatre, and those trends are both afoot around the country or around the world, then something happens that at 3 o'clock in the afternoon, you have to, I'm making this bit up, but something like 3 o'clock in the afternoon, you've got to stop down tools because your patient has to come out of anaesthetic soon enough to be able to go home that day because it was day surgery. Well, not if you've got a 23-hour ward and they can spend a few hours or overnight in that facility and go home, sometime the next morning. Then you can continue day surgery through till 5 or 6 or whatever it is, and so the efficiency improves. But those 20 beds are not inpatient beds either, because you don't count to be an inpatient until you've been in a hospital overnight for a day, and that's why it's called a 23-hour ward. So there we are. That's me just giving you some idea of the changes in the models of care. I'm not a great expert on it, but it's something like that. I've got a few more slides and we're done. The first says, we are not there yet. We haven't finished designing this bloody thing. We've got some problems with the new decision we got from ministers in December, which we've got to resolve. At the top of most people's list is pathology, collaborative at workspace. But there are also some things that we don't know about, the unknown unknowns. And we will come across those at some point. And then the last sentence on that slide is a reminder that this building has an awful lot of IT in it. And I'm not even beginning to talk about that today. It's expensive, it's important, it's another session, if you will. But I'm just going to use that line there that will have modern IT capacity. That's all I'm going to say about it today. And then there's a bunch of things that concern us all as members of the public, which are not in the core project. The core project is to build a hospital. The core project is not to build a car park, but there has to be a car park, or at least the general view is that parking facilities will need to be improved from what they are now. Creche facilities need to happen. And, try opening a hospital that hasn't got creche facilities and see if you can get anyone to come and work in it. The physio pool is just a bit of a Dunedin icon, and they've had a concern that the hospital would be built on top of it. It won't. The physio pool's got its own problems, and the trust will need to decide what to do with it, but the new hospital isn't going to intrude on it. And we've got no decisions yet on what will happen with the existing hospital buildings, something which we are asked a lot. I've got a personal view, which is that the clinical services building will almost certainly come down and the ward block almost certainly will not, but those decisions are not taken. We've got some exclusions of mental health services and Southern Blood and Cancer, which are not part of the hospital project. It's a full hospital rebuild except for those two services. And then importantly for me, and I think for all of us, is this thing called the Interprofessional Learning Centre, which is, in one sentence, an improved way of turning out high quality health professional graduates. And that's important to me, and I think to all of us, because that sits at the heart of the future of the Dunedin economy. And it also means that if we've got a reputation for producing still better graduates, then Te Whatu Ora will be a benefactor as well, because they will be better graduates. They will better understand what other health professionals do for a living, because they will have been trained or taught or educated much more together than they are now. That's the Interprofessional Learning Centre. My last slide, you'll be pleased. This has got 2080 written on it. There are master site plans that are in the intervening decades that I haven't put up there. You don't try to understand it all. Do see where the railway station is. It's the brown thing at the top right-hand corner. You can see the triangle, which is the missing bit. That's the pavilion, where it's just to the left of that thing called NDH. You can see a P, which has got an orange building. That's P for parking. You can see just in front of the railway station, SBCS, Southern Blood and Cancer Services. That is an acknowledgement that the current Southern Blood and Cancer Services, which are in a building that was built in 1993, will in 10, 20, 30 years be almost certainly shifting south. There's that ILC I mentioned in the pale green, and then there's a thing called the TRC, the Translational Research Centre. That's an eye in the beholder of the university. It's a thought in the eye of the university that's beheld by them. It would be their building if it were to be the case. There's an S, which is the substation for those of you who worry about it. MH is for mental health if we bring it down from Wakari sometime, and so on. So that's what the future of this part of Dunedin looks like, and can I just thank you for your attention. You'll just jump up. You'll just get to see these people, these other people I mentioned at the beginning as time goes on. Sir, who's going to run microphones around?
Hi, my question is, do you expect higher lift in efficiency? So, and you must have an expectation of demand in 2035 or whatever it is, or 2030. What percentage of meeting that demand is going to be met by the increase in efficiency?
Met by?
Using IT.
Yeah. I'll give an inadequate answer, and then we'll see if others can improve on it. So it depends on the service. So if you have a look at the detailed business case, which is a public record, it's all there, and you'll see in some cases 30% would be the answer to your question, in other cases somewhat less than that. So it varies from service to service, but the important thing is that we have built this thing to be efficient, and we do need changes in primary and community healthcare and in IT to deliver that. So,
I'm sorry, my reading of the document indicates that you're going to increase efficiency by about 80% because you've got capacity to meet demand.
Did you say 80?
And I've read the whole of this place and I've asked the questions repeatedly from the ministry.
Yeah, so there's no increase in efficiency of 80%. The only thing that you might have been reading there's one statement in the detailed business case that speaks of saving 80% of patients' time. So that my friend from Wanaka waited 5 hours for an eye appointment yesterday and then had to drive home. That's what we're trying to deal to. That's the only thing where I can think of anything where there's going to be an 80% reduction. There's no such figure in the detailed business case other than that instance. Yeah.
Two questions. In the accounting of this exercise and budget involved, what was allowed for the offsetting of this cost with the disposal of the existing hospital and its building? Is that offset? Should be not. And the second question is, I think when I read it in the paper today, what actually is going to be lost by the loss of the provision for the staff? And because we're going to go, what will staff actually do when we have in that facility?
Yeah, I might get you to ask the second question again in a minute, but I think I've got an answer to the first question. The likely value of the current hospital is negative. It's likely to be negative. So if I were to offer it to you for $1, you might say thank you, but no thank you. Because you would look at it and you'll find that this, that and the other needs to be done, rates have to be paid, I can't get anyone to go and live in it unless, etc., etc. So it is likely to be negative. I don't know whether, I don't know that that's the case, but that would be my best guess. Does that answer that first question? Thank you. Could you please put the second question again?
The second question was, what was supposed to happen in the pavilion? I understood from what I'd read in the paper that it was a sort of a workspace for staff. Presumably they have a workspace already somewhere. What will they do if they don't have a workspace?
Let me introduce you to Dr. Sheila Barnett, who chairs the Clinical Transformation Group.
Thanks for your time today. The pavilion was primarily the staff facilities, though it did have some other clinical and imaging. And everything that's been in the pavilion, apart from A small loss has been accommodated in either the use of the dairy building, which has the nice word of relifing, or in the inpatient building itself. So the ultimate loss of area of collaborative workspace is looking to sit around 6%, but when we redesign that and actually put the desks and the spaces in, it looks like we're going to lose around 36 workstations from a total of about 670. And I hope that we can get that a little bit better. The other functions that are really important that were in the staff pavilion were things like parenting rooms, staff wellness rooms, staff sleep rooms, staff canteen, the RMO room. So all those things that are really important to staff welfare, and those are all being preserved and they will be within the inpatient building. The other approach to the collaborative workspace is that previously it was in the pavilion, so that big triangle building, and they were larger spaces. So that has been essentially redistributed into the inpatient building and the dairy building. Within the inpatient building, we have used the smoother boundary of the building to provide pockets of workspace throughout the building. And some of these, in all honesty, have actually been good. So obviously we were pushing against these changes and have been doing so for a long time, but we've also been working with the project to minimise their effects or get the best out of it where we can. And what we have been able to do is get some of the workspace right beside the clinical zone. So previously it was in that pavilion building, and there was quite a long journey from somebody who worked on, say, level 8 in the wards down and across to the pavilion on the first floor, and then potentially up again. And now we do have pockets of workspace on most floors that can support clinical activity. And just to be clear, when we talk about that collaborative workspace, we're talking about additional workspace. So the workspace that was within the units, like a staff station or a staff workroom, that has just stayed as is. And so I think we are reasonably comfortable with the outcome, and that is with the caveat that we do not want to shell 1,000 square metres of it. Yeah. So one of the proposed savings to make up to that $90 million was that 1,000 square metres would have been shelled, and I think we have said just really clearly that that's just not going to be clinically workable. That shell would be empty. It is easy in the project sense to bring those spaces back online.
Did people roughly hear all that question? No. So this is a reference to Dr. Martin Fields, ENT specialist, who's in the paper saying that he, as far as he was aware, that the hospital should be 135,000 square metres, and that it's been reduced time and again on his watch, and he's becoming distressed by that. It's now as low as 83, and what is my answer to that? Here is the answer. I've been involved with this project for 5.5 years, and a figure of 135 has never crossed my desk, ever, not by a country mile. The indicative business case of July 2017 was 93,000 square metres. The detailed business case of March 2021 was 91,000 square metres, just under. I don't know what the gross floor area of the building is right now, but I do know that it is more than 89,400 square metres. I don't know more than that. I'm pretty sure it'll tick over 90. But all of these figures are about the same. All of them are a great deal more than the 70,000 that is the current hospital, and all of them are a great deal less than 135. There is no 135,000 square metres. Go.
I think pre-2019, and I think what Martin's referring to is that there was an iteration very early on when we did some of the original planning, which was quite a lovely process where we all basically asked for what we wanted, like what we thought would be clinically advisable based on our knowledge of what we do and the space we need to do it. And when that was all added up, that added up, to my knowledge, to about 123,000. I'm looking at Bridget, who's the content expert, and Hamish, who was the programme director at the time. And that was just felt to be probably a bit ridiculous for the budget that it would take to build that square meterage of hospital. And there was a relook at that time, and the specific, what we call capacity, or the number of theatres and beds and rooms, was looked at a lot more sharply in the context of what we should be doing, and that's when there looked like there was a reduction at that time. Bridget's nodding. Yep. So that was, to the people involved in the project, of which I was one, that was a sense of loss. That was that we thought we were getting something, and then it has been reduced down, and then it's been tightened and challenged, and not unreasonably, and there's been happy times and sad times through that, and it's been tightened a bit more. So for people that have lived through the project like Martin, and those of us that have been in it for years, it has appeared to be tightened, and that has been a difficult pill to swallow at times. But sitting in the project like this and watching the tightening and the challenging, I think that we are getting to a place of a realistic, buildable, operationally efficient size, and it's people like Hamish that need to be able to run this thing. So I guess in summary, it's that people have been on a long journey, and it has been a feeling of progressive loss, I guess. But what we have ended up with may actually be a very reasonable and good outcome from it.
We should also, in reference to Martin Field's 83,000, we got down to 73. You know, the opposite happens when you bring up hard asses from Australia and say, what is the minimum hospital you can get away with? You can end up with figures way down there, and we've been there too. But all of the resting points are at or near enough 90. Sir.
So I'm glad to see that, yes, sir, is correct. I'm glad to see that there is a long-term plan for where to move the mental health facilities. I'm a little bit concerned that you've said that there won't be any mental health facilities on the new development, and that is because I'm concerned about where emergency psychiatric services will go. It's quite important that that is located in the emergency room. So I would just like some assurance that that is going to be located in the emergency room, because as it is, it's so far away that some patients still manage to elope.
Bridget Dixon is the program manager for the client. So she's the boss lady for what we locals want. Okay, here she is.
Kia ora. Just to answer the question, within the Dunedin Hospital, there is a emergency psychiatric service, and that sits alongside the emergency department. And so that is included. What Pete was referring to is the existing mental health facilities that are located on the Wakari site, and that they are not within this particular project. There is also the mental health services of older people, which is also included within the Dunedin Hospital.
You're doing pretty well, Ian.
I'd just like to ask a very basic question. I mean, we've got these signs here to save and fight the cuts. What is the government's justification for asking for this $90 million cut?
Well, it came down to the fact that the blowout, and normally when you build a hospital and you get a bit of a price increase are a bit of a fright. You've got contingencies, design contingencies and construction contingencies and IT contingencies, and on it goes. And we've got those. But what happened to us because of COVID and trade and Ukraine and all of that stuff was that there were increases, and still are, increases which the greyheads, the people who understand construction, have never seen in their lives before. They are figures that are frighteningly large. And I'll just say one more time, they haven't stopped. So the government said, well, we can't, you won't be able to do this by contingency alone. We will have to put in some more money over and above contingency. That's turned out to be, we thought it was going to be 100, it turns out to be 110, and we were supposed to be finding 100 and we found most of it. So that was just how that arose. I might make another point now, if I may. It takes a bit of understanding, but when you, and I've learned this as an amateur, but here it comes. When you are, got you, ma'am. When you're building a building, if you decide to change the design in a big way, you end up incurring more costs. You get halfway down the track and say, oh no, we're not going to do it this way. So you end up incurring more costs. The two main drivers of costs are the cost of redesign. Warren and Marnie, the main architects, are doing, their fees will go up. And the cost of time, the cost of time, just the passage of time, not including the social cost of time, which is never well monetised. So you end up costing yourself by trying to save money. And so you end up with the idea of net savings and gross savings. And the further you get down the track, the bigger the gap between the gross savings and net savings becomes, until it just makes no sense to redesign. You're just so far down the track, just get on with it. And that's what has happened with the outpatients building. It's remaining untouched because it's so far down the track. The inpatients building will soon be so far down the track, it'll reach that point. And that's why I think further cost increases will have to be absorbed by the taxpayer.
Kia ora, my name's Holly, I'm a laboratory scientist.
There's a woman at the back, if you don't mind me saying, she's had her hand up for quite a long time. Would you mind? I promised to come to you straight up. She's been there for a while. All right.
Okay, thank you. I'll pass you the microphone.
All right, then, so you're going to...
Yeah, so I'm a laboratory scientist and an educator. It was great to see pathology on the screen. So I've observed that my current colleagues in the hospital laboratory here don't currently have enough space for the complex work that they do and the complex instrumentation that they need. So I'm just looking for an assurance that there will be adequate space in a fit-for-purpose laboratory.
Let me ask Bridget back, or Bridget and Hamish, one of you, come and, can you do the pathology one? Yeah. This is Hamish. Hamish is the manager of Otago Southland, really.
Yeah, look, I guess my first comment would be to say that pathology and pathology services are absolutely essential to the functioning of a modern hospital, and we couldn't do without them, and we couldn't do without the teams that work there. So we need to work through, I guess, what the ultimate solution will be, but we can give you absolute assurance that there will be pathology services and they will be fit for purpose for the hospital.
Thank you for your patience. Oh, not yet. Suzanne, there's a woman at the back who's had her hand up for a very long time.
Thank you, Pete. Anne Daniels. I work in the ED. Right now, most days, we actually have 60 plus patients in the department lining the corridors. I understand from your presentation that there's about 52, 53 beds coming up in the new build. So the maths doesn't quite work. We're already behind the 8 ball, as it were. My question to you is there going to be a specialty direct admit that will take those patients out of the ED and leave emergency for emergencies? And secondly, is there going to be a car parking right close to the emergency department? Because we get a lot of people turning up in their cars with people literally dying in their seats. So that's going to be quite important for us so that we can provide timely care.
Okay, here comes an answer.
Thanks, Anne, for your question. So alongside the 53 emergency department spaces, there is also on that ground floor a 32-bed assessment and planning unit, which is both to support that direct medical admitting, surgical assessment that you've talked about. As Pete alluded to, access for people via car, whether that's short-term drop-off or car parking, is an important consideration. And we've got a range of car parking, short-term drop-off, mobility car parks, accessible car parks, emergency car parks, both on the northern and southern ends of the inpatient building.
How much are you going to increase the capacity?
Of what?
Percentage-wise. You know, you're behind today. So how much more do they need to add?
They've answered the question, sir. They're going to take about 20 or 30 of the, what we call specialty patients out of the ED, and that will actually give us an immediate space for emergency.
Is it enough?
Yes, I think, well, I hope so. With an aging population, who knows?
Hi, good evening. I stand before you tonight, or sit before you tonight, as a mother, an employee of the hospital, and a recent committee member for the daycare. And I'd like to take a few minutes to speak with you about the importance of the on-site daycare for working parents like myself. As many of you know, the hospital has been an integral part of the community for years, and it has been a source of pride for us all. We, the hospital management, the staff and parents, take great pride in the level and care of service that is provided here, and we want to see it continued for many years to come. As a working parent, I know firsthand of the challenges that come with trying to balance work and family life, and it is not an easy task, and it requires a lot of juggling and planning. That is why I'm so grateful for the on-site daycare that is provided here at the hospital. The daycare has been a lifeline for me and many other working parents in our community. It has allowed us to continue working while also providing our children with a safe and nurturing environment. It has also given me the opportunity to continuing my breastfeeding journey, to continue breastfeeding my children while returning to the workforce, which was quite important to me. Now, I understand the concerns about allocating funding for a new on-site daycare when the hospital is being built. But I would like to remind everybody that this daycare is not just a convenience for working parents, but it is a crucial part of our community infrastructure. Without the daycare, many parents would be forced to make difficult decisions. Some may have to quit their jobs or reduce their hours, which would have a significant impact on the livelihood of their livelihood and our local economy. Others may choose to cease their breastfeeding journey earlier than they hoped. And as you know, our hospital is part of the wider Baby Friendly Initiative, which is spearheaded by the World Health Organization and UNICEF. Te Whatu Ora Southern promotes positive attitudes towards breastfeeding and a breastfeeding-friendly culture at work. So I urge you to consider the impact for a lack of funding for a new daycare would have on our community. And I urge you to think about the working parents who rely on this daycare to provide for their families. And I urge you to support the allocation of the funding for the new on-site daycare when the hospital is built.
Okay. So I've just gone back to that slide to list a bunch of things that are and we use the language out of scope. In other words, the detailed business case had things to do, and creche facilities are not amongst them. And yet, as I said in my opening remarks, you can't think of opening a hospital without good creche, or as you call them, daycare facilities. Well, yep, we got some more to say.
Thank you for that really well-worded question and perspective. I think all of us in the room are absolutely committed to ensuring that we do have accessible childcare for our staff and parents. Within the publicly available site master plan document, within that there's a lot of detail about the elements that Pete's talked about that are parallel pieces of work that we need to consider as a health service, and creche and childcare facilities are one of those elements that were really detailed consideration within those documents. Would be more than happy to talk that through with you in more detail, but within that image that Pete shared, the 2080, if we showed you the 2030 and 2040 image, we've got located zones for where a possible future childcare facility could be within the health precinct once the current location is deemed to be too far once the inpatient building closes. The other important element is about promoting breastfeeding or parenting activities within our outpatient and inpatient buildings for staff and for visitors and for other parents that are using the buildings. And within both buildings, we've got numerous numbers of parenting rooms. I think off the top of my head, there might be 4 in the outpatient building, and I think there's something like 10 in the inpatient building. Thanks.
Okay, John.
Thank you. This is not the presentation I was expecting today.
It's not?
It's not the presentation I was expecting today.
Oh, I'm sorry to disappoint you.
Only 2 or 3 weeks ago, I think staff in a webinar was showing floor-by-floor diagrams of what the new building would look like and helicopter view. So I expected some diagrams today. I expected some view of what the hospital would look like, this information block, and we're not seeing it. And I thought if you showed that photograph, a picture of the new block, it would look quite impressive and might reassure the public that it's going to be good. Can I suggest the fact that you're not showing the diagrams is that without keeping in gear? There's a change without keeping in gear people. That it's not quite ready to be public.
We show them at a press conference this afternoon, John. There's no secret.
Well, they're not being shared with the public.
We can share them. You know, it's how long do you want me to speak? And so that's all. I just thought that the to and fro would be more valuable to the public.
I suspect that
No, I'll take your advice. We can easily do a floor-by-floor analysis at some future meeting. And Bridget is an absolute wizard. She's got it nailed. So we can do that. But I've if I've misjudged it, I apologise. But I've tried to think about the things that the public would be interested in, and in your case, I might have got it wrong.
In the slide you put up earlier on, you pointed out that tools such as the PET scanner could be added as the needs arise. It's one of those things that has been shelved. We have some MRI scanners, but we have no PET scanner here at all. Are you saying that somebody on the project has decided that there is no need for such an important diagnostic tool?
Professor Patrick Manning will give you a good answer for this. He's the Deputy Chair of the Clinical Transformation Group, or whatever it is.
No pressure. Yeah, that's a good question. I mean, PET scanning is one of those things which is going to become commonplace, I think, in a tertiary hospital in the future. And when the value management option came out in August of last year, this was one of the obvious things that we were very concerned about. They'd taken away the space altogether for a PET scanner. And we felt that was very short-sighted. And you probably have heard of the clinical impact statement that has been alluded to. This is where, when that report came through, that value management option came through, and we looked at all the changes that were going to take place, we wrote a clinical impact statement, and one of the things was we pushed back on the PET scanning issue. And they have now put back into the design a space for a PET scanner, and it will be appropriately shielded for a PET scanner to go in there. There isn't the funding for the actual PET scanner at this point, but that'll be something which we'll have to look at how we resolve in the future. One of the issues with PET scanning is that there is no public hospital in New Zealand with a PET scanner. All PET scanning is done in the private sector, and there really needs to be a national policy for how PET scanning is going to be provided in the public sector in New Zealand. And I think that's something for central government to work on. But rest assured, we have a space for a PET scanner in the future. And there will be a local one coming in private as well. Yeah. Yes. So currently what happens for people in the public sector who need a PET scan, it is provided in the private sector, but it's paid for by the public sector. So worst case scenario, someone who needs a PET scan would have it done privately in Dunedin, paid for by the public sector. But we're hopeful that by the time 2029 rocks around, we'll actually have a decision made that yes, PET scanning will be provided in the public sector and we'll be able to get one into the hospital.
Oh, thank you. Am I allowed a second question? I'm just following up indeed on the PET scanning. Now, you've used the expression several times that the hospital will be state-of-the-art. And indeed, as Professor Manning has pointed out, PET scanning is state-of-the-art. But what you're offering us, at least for the time being, is an empty room, a beautifully shielded room, but a shell room. So to use the expression state-of-the-art, but a PET scan, it's like a pub with no beer, a hospital with no PET scan. And furthermore, sir, you have been reported, if I'm getting it correctly, I think you said it made no sense for the country's first publicly funded PET scanner to be in Dunedin and it should be in Auckland. So should you not, as a local, be standing up for our interests as Dunediners versus Aucklanders?
Yeah, so when I did make... You're absolutely right, I did make that statement. What I couldn't say, because it wasn't my information, because it wasn't for me to say it, was that the private sector was going to move in providing PET scanning in Dunedin from next year. And that subsequently has been made public. So everyone now knows what's going on. I wasn't in a position to say that because it wasn't my PET scan. But I just would reiterate Patrick's remarks. My own view, just because of where I sit on the political spectrum, is that PET scanning should be provided by the public sector. That's my view. At the moment, it isn't. The first PET scan arrived in 2006 when I was Minister, actually, and that was in the private sector, and it's been private sector ever since. And I think PET scanning should be provided publicly. But what we need is the Minister or the government or Te Whatu Ora or the Ministry of Health or someone like that to give some thought to that. And in the meantime, we've got ourselves room for a PET scan. I'll make one other point, which Bridget makes better than me. When you're building a hospital and you're thinking you might put a PET scan in later, you've got to put all the bits and pieces around the PET scan in when you build a hospital. You could call that warm shelling. you've just got to plug the PET scan in at the last minute, and that has a really useful role. It means that Te Whatu Ora will be in a strong negotiating position when they're trying to work out the price per PET scan from the private sector, in light of that gentleman's remarks that we need to have free access, whether the public provision, free access for the public, irrespective of who does the provision. So hopefully those remarks are helpful. Ma'am, Terry, we've got Terry's had his hand up. That's that guy there.
Now most people can hear me. Can everyone hear me? So I'm Terry Taylor and I'm the President of the New Zealand Institute of Medical Laboratory Science. My interest was here tonight to do with the pathology allocation for the hospital, 350 square metres, which is totally inadequate and really an embarrassment and a kick in the pants for all of the scientists and technicians in this country. We need to be looking at putting together a pathology laboratory which is worthy of the tertiary hospital that we have here and the training provision that we have here as well for our scientists. I would say with the PET scan, how about give up the 350 metres for that and give us a purpose-built building that's fit for purpose, for operating in this region. That would be my big thing there. We've got to look at what we're going to do into the future. 350 metres is basically a joke.
Righto, Terry, I don't think there's a question there. Thank you. There's a woman here who had her... I'm sorry, sir, but I'm going to go to this woman first, if you don't mind, because you've had a couple of questions.
My question, a bigger hospital means more staff, and while it's not directly related to the building of it, where do you envisage all these staff who...
Bloody good question. Hamish.
Shift work, where are they going to be parking? Because buses, you can say walk or bus, but it's not always safe to walk, and buses don't always run at the right time. Having worked 30 years a night shift there. But
transport to the hospital is not your question, it's where to, or is it?
Well, it's how are these staff going to be looked after? You're not going to have staff if you haven't got facilities like parking.
Yeah, okay, well, if it's about public transport, have a talk to the local government, but, hey?
We don't have to keep listed for the office. Public transport. It's all I say.
Yeah, I said local government, I didn't say DCC. I mean, if your question's about public transport, that's not us. But could I ask Hamish to tell you a bit about workforce? Because, I mean, we've got to find these people in the first place and then transport them. So
you probably have more chance if they've got somewhere that they can park safely.
Well, parking's an issue, and I've got a... Here's where the parking building might go. Do you see that orange thing with a P on it? Yeah. But anyway, I was hoping you were going to ask about workforce because it's such an important issue. Let me ask Hamish to make a comment about it anyway.
Yeah, look, thank you. And I guess the first comment that I would make is that without an engaged and well-functioning workforce, then the building is nothing, actually. It's the people that
speak up, please, because we can hardly hear you at the back.
It's the people that make the hospital, and it's the system that they work in. It's not the building. The building just enables that workforce. So there's a couple of points that I'd make. One, Pete pointed out on the site master plan, the Interprofessional Learning Centre, which is a project that we're working together with Te Pukenga, the Polytechnic, and the University of Otago around interprofessional learning and creating the health workforce for the future. There's also, as part of Te Whatu Ora, the Health Workforce Task Force, which is looking at numerous workforces and how we build and sustain and train and keep people local. Locally, we've had some success in attracting workforces. A lot of our departments across Dunedin Hospital and indeed Southland Hospital are fully recruited. and we've got lots of other people coming in. We do have some critical workforce shortages in some areas, and no doubt people have heard about the anaesthetic tech shortages in Canterbury, which is hampering some of the planned care, and there are some national initiatives alive around those things. But I would say how we look after our workforce and how we retain and value them is absolutely essential to the success of Dunedin Hospital.
A related question, you're talking about moving from 8 to 10-hour operating shifts. What's the impact on that, on the staff and utilisation?
Sheila's probably better equipped to talk to some of the detail, or perhaps both of us. Most hospitals do have a longer operating day, and there's more staff. We require more staff to manage that longer day, but it means that we can get through more patients and use, I suppose, the theatre time more efficiently, and that's particularly important around our acute operating. So if we have short acute operating days, then people tend to stay in beds longer, and that doesn't help the flow within the hospital. Have you anything that you want to add to that, Sheila?
I think just the addition of, one more small point that I agree, I think you summarised it well, just that a move to a longer day. A move to a longer day does have an impact on staff and needs to be worked through. It's not just an assumption, it's something that will be worked through with all staff groups, including the unions, and with the consideration of the impact on staff welfare of potentially working into more evenings or potentially weekends as well. Plenty of other areas of the hospital have been doing this, but it's something that I think we as clinicians would highlight as not a done deal, just something that can be worked through and will help you use that really expensive resource better if it's done sensibly. Yep.
I've got a question. I've got a question about these shelled workspaces, so which may actually be needed at the time of opening of the hospital because it's still a few years away. When it comes time to commission those shelled workspaces, what will happen to the stuff, whatever facilities and services or equipment is stored in or sitting in those rooms? What will happen to that when the rooms come to be commissioned?
Okay, so the only difference in shelled workspace for the shelled collaborative workspace issue that you're raising is the two theatres, each at 55 square metres. Now, Sheila, am I right?
It will be 60 square metres, but yes.
That's 60 square metres. Yeah. So you raise an issue, and I'm just going to proportion it for you. We think we've got to 120 square metres, and we think the total for collaborative workspace sits at about 3,100. So that's the size of your question. 120 metres out of 3,100, something like that, Jules. So it's an issue, but it's not a big issue. And what Jules has said is that when we unshell the last of the surgical theatres, maybe 10 or 15 years from now, we'll lose a bit of collaborative workspace as we do that, because we're using it in the meantime for that other function. He's saying, what are you going to do about it? And I'm saying, you've got an issue, but it's tiny, 120 square metres out of 3,100, I think is the right answer. So that's, I don't know what we're going to do about it 15 years from now, but I'm not greatly exercised by it. Yeah.
So in terms of the pharmacy and the pathology areas, which are quite a large area that's now been taken out of the build,
it is.
Why not just put a bit extra on the ends of the buildings, because the building's been extended on either side and either end. If there's a little bit more on either end, on one of those ends, surely that would accommodate the pathology, which many of the surgeons I've spoken to are very concerned about the time taken to get results back when in the middle of an operation?
Yeah, I'll get Bridget to talk to you about acute pathology and 24/7 pathology and stuff.
So just to answer your question in two parts. So the first part in relation to the pharmacy. From the original plan to the current plan, the only change is that the aseptic production suite has been assumed to stay in its existing site, which is in Southern Blood and Cancer. Now, we are working through with the pharmacy team to ensure that the viability of the production suite can last for a longer period of time in Southern Blood and Cancer. So that service will be able to be continued on a two-site operation. To follow up the question about pathology, we are working with the current provider and the clinicians to understand what a on-site stat 24-hour lab can deliver within the current footprint, proposed footprint. We will be working through that with the current provider and also seeking independent peer review within that process. So that piece of work hasn't started, but we are still underway. We don't have that final answer yet.
I might add that Bridget was in Australia last week looking at this sort of stuff, and there is plenty of change afoot, Terry, as you probably are aware, and so we're trying to take the most modern and up-to-date decisions we can.
Hi, I work in ICU. I've been there for about 23 years and in ICU since the early 80s in other hospitals. And I'm sorry, I just need to say something because
I can't hear you. Can you please start again?
Okay. I just wanted to correct something that Hamish just said about full recruitment. I know I'm not talking about the building. It's great about that professional building that you just talked about. But you can't quite say that we're at full recruitment when most nurses are getting texts every day about doing overtime. There would be a very rare day that my phone doesn't have a text asking 2 or 3 times a day to come and have extra nurses in the ICU. And most places around the hospital are like that. On April the 15th, the nurses are going to be walking down down George Street talking about that so that we can bring it to the public attention. As this is a public forum, I didn't want that to be known by the public that we're at full recruitment. That is not true. 45% of the nurses in New Zealand are internationally qualified nurses. That means that we are relying on people coming from outside of our country in order to look after people. My unit alone is now 43% of the nurses are internationally qualified. Wonderful building, that'll be fantastic to draw people into coming to train and be part of, I don't know about the medical staff, but nursing in particular, to train in Dunedin. But I don't mean to be critical, but I just couldn't sit here knowing that I'm going to be walking down George Street in a couple of weeks, knowing how short we are, and let that go. Sorry, thank you.
Jim.
You said that the architectural changes are already bringing in about half the savings. So if that 90 million shortfall has now dropped down to 45 million, my question actually isn't to you, it's to the 2 PAs of our local Labor MPs. Why can't we just close that gap at this point? If this is a decision of Cabinet, I guess, because I know that in this room, and I don't want to put anybody out under pressure, there's nobody in this room, because I've asked this question before and nobody put their hand up, who has authority over the final budget of the hospital in this room. That's outside of this room.
Yeah.
And I have seen what you've done, because luckily I've seen some of those slides too, because you have briefed the council very well, I want to point out here. That gap is getting closer and closer to being closed. So why can't we send a message back to Wellington, close the gap with a cheque, and then we won't have to have this debate any further? Because there's probably a few more architectural changes you could make in that main block building that could bring that another 10 or 15 million closer and get that even smaller.
You know, you make a good point, Jim. Can I make it using other words? If I'm... You know, you're right in saying that I can't have it both ways. If I'm going to claim that way over half of this $90 million is non-clinical, that means that way under half is clinical. And you're saying close it. And that's fair enough. Thank you.
Thanks, Pete. Thanks, Pete. This is the question I was going to ask about the governance of this whole project. I'm sure the local team have done their very best, you know, to do the best with what they're given to produce the best hospital possible. But in the new system, it's governed by Te Whatu Ora rather than the ministry. And I see that above the project team, there's an executive steering group. And on that executive steering group, there are 3 senior responsible owners for the whole project. Who are those 3 senior responsible owners?
They've just been changed out. The executive, and I don't know the answer to your question, the executive steering group met this morning in Dunedin and elsewhere. It's one of those hybrid meetings. And it will be replaced by, Te Whatu Ora has decided to change the governance around a bit, and it's going to be replaced by, what's the new one called? Is it a project steering group? PSG, not ESG. And some of the personnel on that will be swapped out, will be changed, and some won't. And there will be almost certainly a senior responsible owner for IT, a senior responsible owner for the transformation, is that right? Transformation program, and a senior responsible owner for the building. That's where I think we're going, unless Dan and Fiona know something different. And I don't know the names of any of those people, John, I'm sorry. But the project will be, by the time the new SRO for the building is announced, when I do find out who it is, it will be the 6th person holding that job since I started. And that tells you that we are not, as a country, we're not that good at building hospitals. And the underlying reason for that is that we have not built very many in the last 10 or 15 years. And the exceptions to that are 2 in Christchurch and 1 in Greymouth. If you add those 3 hospitals together, they would not, in total, meet the budget of this one. Oh, actually, I better say some more. But we're getting better. Te Whatu Ora has established a unit within it called Infrastructure and Investment Group. Its chief executive began work probably 2 months ago, and it's an encouraging change. It's one that mimics what is going on, or has been going on for a long time in both New South Wales and Victoria, which is where the ideas came from. It's now that I've seen it forming up, I regret deeply that I didn't put it together when I was minister all those years ago, but I didn't. And I think that will mean that we will become better at building hospitals than we have been. Are we done? Well, I've got one question for you, which is, has it been vaguely useful, and not you necessarily, but should we be doing this more? Okay. Thanks, everyone. Hey, don't go. I've got these are, if anyone wants details about exactly what's in the thing. Can anyone hear this? Anyone want these handouts?
I'll stand at the front and give them.